At first glance, US healthcare appears to be in a terrible state. US patients pay close to 3 times more for prescription drugs than they would living in other countries, making life-saving treatments unaffordable to many. Affordability issues aren't particularly surprising given that there is no universal healthcare, which resulted in over 30 million US residents not having health insurance in 2020. You've probably seen charts similar to this, which show that despite unparalleled healthcare expenditure, US life expectancy and many other health outcomes fall short compared to other nations. The public debate often singles out drug expenditure as a single driver of overall expenditure. That's reasonable, partly given that the US roughly makes up half of the global pharmaceutical market, and hence pharma companies tend to see the US as their main profit center. But do these charts really tell the full story? Appropriate drug pricing is often seen as a trade-off between affordability and innovation, but does it really have to be that way? Peter Kolchinsky, who's the author of a book called The Great American Drug Deal, answers this question with a clear no. He gives compelling answers to big questions such as why drugs are more expensive in America than they are elsewhere, what can be done to prevent price jacking of older drugs, and how can we ensure that drug prices are fair while still fostering innovation. I've learned a lot from reading Peter's book, which is why I wanted to share the key concepts and ideas behind the Great American Drug Deal with you today. Let's start off by understanding what Kolchinsky means when he talks about the Great American Drug Deal. According to Kolchinsky, the biopharmaceutical industry and society are engaged in a symbiotic relationship. He refers to this relationship as the biotech social contract, which he defines as the drug development industry's commitment to developing new medicines that will go generic without undue delay, that is reciprocated by society's commitment to providing universal health insurance with low or no out-of-pocket costs, so that patients can actually afford what their physicians prescribe. This contract implies that pharma companies will be allowed to temporarily charge high prices to compensate them for taking on the financial risks and challenges associated with developing life-saving drugs, as long as their drugs are under patent protection. One thing is very important in this context. While Kolchinsky believes it's okay for drug prices to be high initially, they need to drop to affordable levels eventually. In most cases, this eventual price drop is caused by patent expiry. In most countries, including the US, drugs are typically patent protected for 20 years from the date of filing of the patent. However, this 20-year period doesn't necessarily equate to 20 years of market exclusivity for the drug. According to this figure from the ABPI, it takes about 12 years on average from a patent being granted to a medicine being used in a health system for the first time. That's why in most cases, drug companies who develop a new innovative medicine can profit from high prices for 8 to 10 years before generic competition self-regulates prices. What was most eye-opening to me was how this loss of exclusivity mechanism over time results in a mountain of generic drugs that gets bigger and bigger. About 90% of all prescriptions written in the US today are generics, which at some point were high-priced drugs that are now available for a fraction of the original cost. Peter calls this mountain the generic drug armamentarium, which he illustrates nicely through the image of a conveyor belt where pharma companies capture profits from their novel drugs for a period of time before they fall over the generic cliff, meaning that they're now available for much cheaper and benefit society by continuously improving what's known as the standard of care. Behind every generic, there is also a story of risky and expensive innovation, which our collective memory often likes to forget. The press loves to jump onto the flashy new, super expensive drug once it hits the market, but we rarely talk about the fact that most societies spend way more on service-related costs than they spend on drugs. According to Kolchinsky, service-related costs make up over 70% of total healthcare spending in the US, and sadly, healthcare services never really go generic. That's because these services will always require highly trained professionals like doctors, surgeons, and nurses whose salaries will continue to climb every year. On top of that, the provision of healthcare services typically requires physical space, which is already in very short supply around constantly growing urban hubs. That's why service costs, which makes up the bulk of total healthcare expenditure, will continue to climb up, and yet the public debate continues to focus on spending of branded drugs. Continuing on with this train of thought, we should stop viewing branded drugs spending purely as an expense and instead consider it an investment. In his book, Kolchinsky makes the comparison to traditional infrastructure investments like roads, drinking water, or wastewater systems, which few people would really consider a waste of money. Just as how functional roads and sewage treatment facilities are essential, societies will eventually need the innovations developed by the pharmaceutical industry, and these innovations are made possible through the sales of branded drugs. For reference, the US spent about 2.4% of their GDP on traditional infrastructure investments, while branded drugs represent roughly about 1.3% of the total US GDP. Still, a lot of US residents probably feel like drugs are inaccessible to them, while clean water is very affordable. Of course, this is because health insurance plans require out-of-pocket co-payments of up to 20%, so vulnerable patients disproportionately carry the burden of supporting the biopharmaceutical workforce and building the common stockpile of generic treatments. That's one reason Kolchinsky believes that America's health insurance system is breaking the biopharma social contract. Let's take a minute to understand why this is the case. Since there is no universal healthcare in the US, most people are insured via private or government-funded health insurance plans. The big three government-funded plans include Medicaid, Medicare, and the Veterans Health Administration. Medicaid covers people who are living well below the poverty line. Medicaid is for older Americans aged 65 and above, while the VA covers veterans of the armed services. This, of course, leaves a lot of Americans who are not eligible for either of these plans. But luckily, most of these people will receive health insurance via their employer via so-called ESI plans. However, that still leaves people who don't qualify for either of these plans, which leaves them with the option to buy health insurance via state-run exchanges, which were introduced with the Affordable Care Act. The problem with that is that some patients fall through the cracks and are left without a safety net. Today, over 10% of Americans don't have health insurance, and these people will eventually require some form of healthcare during their lifetime. So, what happens if somebody who doesn't have insurance suddenly becomes ill and requires treatment? Well, since they don't have insurance, they have to pay for that treatment out of pocket. And in 2013, the total out-of-pocket payments made by uninsured patients was about $25 billion. But surprisingly, hospitals locked $85 billion worth of services for which they weren't able to collect payment. As healthcare companies couldn't cover such losses, government had to step in and paid $53 billion for so-called uncompensated care. This amount of money only comes from one source, and that source is taxes. So, in a sadly ironic twist, society still footed the bill for those unable to afford care, only in the most inefficient way possible. As long as we can all agree that a health insurance system should always provide extensive emergency care to everyone, regardless of their health insurance status, then that system is functionally insuring everyone already, just not in an optimal way. If the US were to embrace a system where everyone is insured, making insurance mandatory, the cost of buying insurance would effectively become a tax. And as we all know, taxes are spread unevenly in most countries around the world, and insurance does not differ from that. Funding for health insurance should be collected as fairly as possible from everyone who can afford to pay in order to cover those who need the help. This raises the question of what constitutes as fair, as we can all have different definitions of fairness. This, by the way, is exactly why people have and probably always will be arguing over who has to pay how much taxes, as where we as a society collect our money from has to do with our perception of fairness. Another issue that has to do exactly nothing with fairness is the fact that US health insurance payers have an incentive to let the overall costs of healthcare rise. Now, that's absurd, you may say. Why would payers want costs to rise? That's because of what's known as the medical loss ratio, or MLR. By law, the MLR states that insurance companies must spend 80 to 85% of their revenue on patient care, which leaves 15 to 20% to cover their own operations, with the leftovers being equal to profit for those insurance companies. Here's the crux though. This MLR effectively links their profit to the size of the pie, which creates an incentive for payers to grow that pie as much as possible. Surely no payer would ever say that this is their ultimate goal, given that they're tasked with containing costs. Though mechanistically, they actually don't win by cutting costs in the long run. Another absurdity in the US healthcare system are so-called pharmacy benefit managers, or PBMs for short. In his book, Kolchinsky labels these PBMs as false heroes, given that they prey on the patients. Let's first understand what pharmacy benefit managers are, so we can understand why Kolchinsky has a problem with them. PBS are companies who negotiate with drug manufacturers on behalf of payers. So this effectively makes them agents who act in the interest of payers. And heroically, PBMs will lead tough negotiations with pharma companies to extract high confidential rebates on their list prices to save money for payers. So far, so good. But one important little detail is that PBMs retain a proportion of the rebates that pass through them. In other words, they get a cut of the deal. And this means that PBMs now have an incentive for list prices to be as high as possible so that they can extract a higher rebate from drug companies, which allows them to siphon off a larger profit for themselves. To understand how ridiculous this is, imagine hiring an agent to buy a car for you. The deal you make with the agent is that you only have to pay them 20% of the amount they save you. If a car costs $40,000 and your agent negotiates a $10,000 price reduction for you, you effectively end up paying $32,000. However, if the car dealership would decide to cut out the middleman and offer their best price right from the start, for example, $30,000, the agent would have no incentive left and no room to get you a car from that dealership. Rather, the agent would like to cut a deal with the car dealership to raise their prices to $50,000 so that their commission increases to $4,000. Despite all of that, it's apparently still a hotly debated topic whether payers should rely on PBMs to negotiate prices for them. Kolchinsky argues that if PBMs' profits were to be redirected to patients, this would lower their co-payments by about a third, essentially getting rid of a layer of rent that society can do without. Earlier we talked about the concept of the biotech social contract and how drugs that go generic will eventually add to the mountain of low-cost drugs, continuously improving our standard of care over time. There is one problem though with this idea. What happens if drugs don't go generic? To give you a better idea of the size of this issue, I should say that most drugs will eventually go generic, but there are some which are difficult to genericize and some which outright cannot go generic. So why is this the case then? You see, in pharma we need to distinguish between chemical and biological drugs. When a chemical drug loses its exclusivity, the chemical formula can be shared and copying it is relatively simple and straightforward process. Biologics are different though. These complex molecules are derived from living cells and are therefore more similar to aged wine in the sense that no batch is exactly the same. One step in the right direction is recognizing so-called biosimilars, which allows the FDA to call two biologics similar enough, though it's impossible to actually prove that they're exactly the same. Then there's the category of drugs that are truly uncopyable. Gene therapies are a good example for that, given that their manufacturing is so complex that even if a company would claim to have made a copy, no one would actually trust them that that copy is exactly the same. That's why drug companies who successfully developed a gene therapy may end up in a situation where they have a natural, undisputable monopoly, which undermines the biotech social contract. In these cases, Kolchinsky proposes the concept of contractual genericization. This concept is simple, as all it suggests is to regulate prices of such natural monopolies via price controls. Essentially, drug manufacturers would sign an agreement that says that they will continue to produce the drug following patent expiry at a price that is slightly above the price of production. With a guarantee like this, a company would still be motivated enough to manufacture the drug and therefore maintaining the access to the drug innovation at an affordable price. Similar to drugs that won't go generic, another form of system failure happens when drug companies raise prices for products that are off patent. Kolchinsky calls this price jacking, which can occur when a company acquires an older off-patent drug that faces no generic competition. It's like pharma companies playing the role of thieves, seizing back drugs from the generic armamentarium, enriching themselves on medicines whose development costs society has already paid in full. He calls this a minor issue, given that examples of such price jacking add up to less than 1% of what the US spends on prescription drugs each year. Kolchinsky's solution to this, apart from closing regulatory loopholes that allow drug companies to delay entry of competitors, is again contractual genericization, which I already covered in the previous section. Price jacking is one problem, but it is vastly overshadowed by the fact that drug prices in the US are way higher when put into the context of an international comparison. Looking at this issue, a recent study found that US manufacturer gross prices of drugs in 2022 were 278% of prices in the 33 OECD comparison countries combined. Kolchinsky argues that the fact that drugs are cheaper elsewhere is still good for US citizens, which intuitively seems really wrong. Let me explain why he still has a valid point here. Fundamentally, Kolchinsky argues that high drug prices in the US enable global access to medicines while preserving innovation incentives. Think back to the fact that about 50% of worldwide profits for pharma come from the US. If you believe in the logic that more money equals more innovation, then someone has to pay the bill for that. Right now, a sizable chunk of that bill is being paid for by the US. Now, you might argue that that's not fair and that the bill should be split equally. That's basically like demanding equal drug prices across countries, which sounds fair in principle, but the real question is how that would impact innovation and access to medicine. Imagine for a second that the US would stop paying high drug prices. And if all other countries' prices, and by extension drug revenues, were to stay the same, the total size of the pie would shrink. So as long as you assume that money drives innovation and speed to access, the world would actually see fewer drug therapies come to market and slow down its R&D pipeline. Until now, this remains a thought experiment, as drug prices have consistently been high in the US and have therefore indirectly funded global drug innovation. Remember that if your goal is to spend less money on healthcare, sooner or later you need to deny patients access to medicines that they may benefit from, unless the only money you are saving is associated with inefficiencies. In early 2025, the US government has clearly shown eagerness to tackle inefficiencies and reduce federal spending. Right now, we're all witnessing Doge proudly proclaiming how much money they've already saved on their wall of receipts, which, according to the New York Times, is currently struggling with erroneous reporting. Think of Doge what you want, but there is some peer-reviewed published evidence that estimates the total annual costs of waste in the US healthcare system between 760 and 935 billion US dollars, which highlights the need to address inefficiencies. The authors of that same paper quantify the savings potential of interventions that address waste to be anywhere between 191 to 282 billion US dollars, of which roughly 20 billion is attributed to drug pricing interventions. Getting rid of system inefficiencies in healthcare is certainly something that should be looked into, but one core question remains. What happens if the US pulls back their funding of the global pharma industry? Will other countries step in to foot the bill? Or will we simply accept a lower level of drug innovation? It's certainly a dangerous experiment to conceptualize. In his book, Kolchinsky also talks about direct-to-consumer advertising, or DTCA for short. As a European, hearing someone advocate for DTCA admittedly feels quite weird, given that all other countries, apart from the US and New Zealand, I think, outright ban advertising drugs directly to consumers. Regardless, I was ready to be convinced of why DTCA might benefit societies. A point that Kolchinsky makes in this context is that DTCA caused a shift away from a world of paternalistic medicine where whatever the doctor said was the only thing that counts, now leading us to a world where patients are more informed than ever and can ask targeted questions. After all, if a patient has heard about symptoms or treatments that they've learned about in a commercial, that might spark a discussion with their doctor, which could lead to better treatment outcomes. In contrast to this, critics of the DTCA will argue that pharma companies producing these commercials are purely profit motivated. And they're right, of course. No pharma executive would sign off a massive marketing budget if there wasn't a return on investment. But the point is that DTCA can still disseminate informational value, which spreads disease awareness and therefore leads to improved patient outcomes. While their new product is under patent protection, drug companies will have an incentive to spread disease awareness themselves, which society benefits from indirectly. Yet, once a product loses its exclusivity, this incentive expires, and society must find ways to maintain the knowledge and awareness that was raised by pharma companies in the first place. This is typically done through medical treatment guidelines, which outline the proper use of drugs that all physicians are expected to follow. I won't go into the long list of pros and cons of DTCA here, but reading about Kolchinsky's perspective has definitely helped me get a more balanced view on the topic. By now, we've established that Kolchinsky is supportive of funding innovative drug therapies, whereby the producing manufacturer is recouping their large initial R&D spend in the form of a mortgage payment from society that accepts high drug prices for a short period of time, assuming that drugs will go generic in due course. So far, so good. Unfortunately, pharma companies know a lot of tricks and they can afford to hire well-paid lawyers and ex-regulators to achieve patent extensions for existing products, which has the potential to violate the biopharma social contract. We're not talking about new drug therapies here that undoubtedly justify a new patent, but rather it's about incremental innovation and how that should be reflected in pricing. For example, how much do we value the convenience of moving from an injection to an oral tablet? Are we willing to pay more for a drug that we can take once every 3 months compared to a drug that we need to take daily? Assessing the value of incremental improvements is difficult, and handing out new patents for stepwise innovation sometimes results in too much reward, and sometimes it results in too little reward. Pharma companies are clever enough to make use of gaps in the regulatory system that awards them new patents for existing treatments by only making minor tweaks for their products, where they essentially dress up an old dog and get paid handsomely for this new trick. There are examples out there where pharma companies have made billions using this approach, which is why Kolchinsky advocates for short exclusivity extensions rather than granting long patents. In this context, he is also broadening the debate by asking how much societies are really willing to pay for incremental innovation and how this innovation is incentivized through payers. Take the UK, for example. NICE still, to this day, uses the same willingness to pay threshold that was introduced over 20 years ago. Is the threshold introduced in 2004 really still the right one to use in 2025? Patients might feel like the benefit of incremental progress is underestimated, but they can't even lobby their governments to change these arbitrary benchmarks of what's considered meaningful if they're not familiar enough with the methodologies and the processes that are used to make reimbursement decisions. Given that Peter Kolchinsky is a biotechnology investor and founder of a capital management firm, you'd be right to assume that he wants the industry to do well, of course, which introduces the potential for bias. If you want to hear an entirely different perspective on the industry from someone who is just as clever but instead believes that medicine is broken, then check out my video on Ben Goldacre's book called Bad Pharma, which you can see on screen right now.